Hello everyone, my topic for this period is that treatment of excess CTO. Clinically, methods of dealing with forearm arterial venous vascular CTO are basically divided into two types: opening with a puncture needle, opening with guide wire. Puncture needle opening will be used in the following three situations. First, occlusive lesions with short lesion lengths. A straight no turtles occlusive lesion. Look at this. Case 1 is a left RC AVI, occlusion of median cubital vein, a branch of the basilic vein. Left video ultrasound short axis shows that the occlusive lesion. The right image shows that the length of the lesion is about 3 centimeters. So the lesion is short and straight. We use a puncture needle to open it. Look at the video. Long axis guidance determines the puncture needle direction and angle. Short axis guidance determines accuracy of puncture. The key point is that puncture needle tip is always in the center of the blood vessel. This is the vascular after PTA. Case 2 is also left RC AVI. The lesion is a wave lesion, straight and short. So we also use a puncture needle to open it. Keep the puncture needle tip in the center of the vascular. What's different from previous two is that this is an anastomotic heel lesion. There was no obvious stenosis in the cephalic vein. There was no obvious stenosis in radial artery. Look at this picture. Here is occlusion in the area of the anastomosis. The lesion characteristics is also short and straight. So we puncture anastomosis to heel to radial artery in the end. What is shown below is the second situation. If the puncture target is too small, use a balloon to expand the puncture target. Let's look at this as an AVG venous outflow occlusion. The outflow vein is too small for us to puncture. At the same time, multiple previous attempts at guide wire crossing result in local blood extravasation and swelling. Therefore, we cannot accurately puncture the outflow vein. We use a balloon expansion puncture target and puncture this balloon like this. Then the guide wire is inserted through the puncture needle. The third situation, I think, is an expanded usage. It's not using CTO. If two blood vessels are close, a new blood vessel can be created by puncture. Case 1 is a left RC AVI. This is a cephalic vein, vascular vein. This is a median forearm vein, non-vascular vein. Radial artery is here. Ultrasound shows that vascular vein is not so good. Long segment lesions. This is a non-vascular vein. We can see there is no stenosis in the vein. two veins now communicate with each other. So first, we place 6 French sheaths into non-fascicular vein, and then we puncture anastomosis to the catheter sheath. It's from non-fascicular veins, like this. This is a puncture needle. This is the sheath. The stenosis is here. The sheath is in the non-fascicular vein. And then PTA with PCB 5 millimeters to 4/6 millimeter. This is a new channel after PTA. Here it is. The key points to this method: close enough to each other, from high pressure to low pressure. Outflow vein are sufficiently patency. Case 2 is a similar case. This method can also be treated when the perforating vein is turtles and stenosis, but it must meet the 3 conditions just mentioned. Close enough, the pressure goes from high to low, and the outflow vein are sufficiently patency. This is median cubital vein. This is brachial vein. We puncture median cubital vein to brachial vein and PTA. This is the channel credit. Case 3 is left AVG brachial artery to cephalic vein. Long segment lesions of the cephalic vein in upper arm cause dilation of blood vessel in elbow, and the pressure in the artificial blood vessel and the blood vessels in the elbow increases significantly. The diameter of the brachial vein was good. Ultrasound shows that the anastomotic vein is very close to the brachial vein here. We puncture graft anastomotic vein to brachial vein line. This is a brachial vein. And PTA, this is a new channel credit. Let's talk about the second way to open a CTO, which is the opening with guide well. This method different from puncture needle opening. Occlusive lesions with long lesion lengths. Turtles, no straight occlusive lesion. Due to time constraints, we show a case. Left RC AVF, we can see dilated vein in the forearm due to perforating venous outflow. Other cause, median cubital vein occlusion, a branch of the basilic vein. We can see that the length of the occlusive lesion is about 5 to 6 centimeters. We can see traces of occluded blood vessels. And this section is very close to brachial artery. The characteristics of this lesion are that it is slightly long, close to the artery, and not very straight. Therefore, it may not be easy to open it with a puncture needle, and there are certain risks. First, we use needle puncture median cubital vein and use the CTO guide well attempts to open the occluded vessel. This is the guide well, Asaki as title 30. Then we may encounter 2 situations. First is CTO guide well opens the occluded vessel. That's okay. The second is CTO guide well goes out of the blood vessel. Look at this case. the CTO guide wire goes out of the blood vessel. This is a guide wire. Try many times without success. We can see local swelling. So how to return to vessel lumen? We puncture the basilic vein and arm at the guide wire. The key point is that the puncture needle must touch the guide wire. Then pull back a little, remove the puncture needle, and keep the cannula. This is a cannula. This side is a guide wire, and try to advance the guide wire forward in other direction. And in most cases, the guide wire will enter the cannula. Because the puncture needle just punctures and touches, it provides the only channel. This is the vascular after PTA. There are many methods to return to the vascular cavity. Look at this case. This is a guide wire. The guide wire is very close to the vascular cavity, but it always located under vascular intima. And then we place the catheter sheath through the guide wire. And keep the catheter sheath close to the vascular cavity, and the puncture needle puncture vascular cavity to catheter sheath. This is the puncture needle. This is the catheter sheath. There has another method. Look at this case. This is occlusive lesion. Guide wire it is. This is a guide wire, very close to vascular cavity, but still under vascular intima. Cannot in. So place the catheter sheath. This is a diameter. The diameter arm at the vascular cavity, and put the guide wire forward into the vascular cavity. The above is a method of opening the CTO that we are more commonly used. Thank you.
Ultrasound guided stent implantation to treat stenosis of AVA.
Thank you, Dr. Bambi. I will talk something about the ultrasound guided stent implantation to treat the stenosis of IVF. In our centers, 5 years ago, we just have to attempt to do this works. And this is the brands of stent that we use guided by ultrasound, including the Bell stent or the Cal stent or the Jagiellonian stent. The stent, as we all know, the stent contain the meshes, the clone meshes. So the feasibility of the ultrasound guided stent implantation is depend on whether the unreleased or the released stent can be realized under the ultrasound. And the unreleased stent is covered by some sleeves. So the sonolucency of the sleeve is greatly related to the availability of a stent. The main body of the unreleased stent under the ultrasound has a fissure bone, like a fissure bone, the echo. So consisting of a strong echo and the committed tail side of the unfolded edge and the folded edge and then the no echo of the stent holes. different stent have different sleeve. So, for example, the absolute stent, the sleeve is made of plastic, and the Innova stent is the sleeve made of spental. So the plastic have the good sonar lucency. So it's in ultrasound we can identify the stent easier. This is the tip of the stent. It's generally good. Most of the stent can be distinguished in ultrasound, and the most important thing is to identify the true tip of the stent body rather than the mental mark. This is the mental mark. This is the real tip of the stent. The identification of the end of the stent under ultrasound is a little more difficult than the tip. So we should find the tip end of the fishbone echo. That's a rare end of the stent. When the stent has been implanted, the immediate visibility of the bell stent is good, and the wall of the expanded stent shows a thin dotted line strong echo attached to the vessel wall. Why we choose the ultrasound to guide the stenting? Because it has the no radiation damage, also low requirement for the treatment site. Also, the cost is also lower. That's not the all, because as we all know, the DSA, the X-ray, the release of the standard may produce different degree of the displacement, which should be adjusted timely. But the angiography is not a real-time method. How about the roadmap? Roadmap also is a static reference imaging before the standard release. It's not a real-time tool. Ultrasound is a real-time method. It can observe the structure details, also can catch the detail of structure, also can catch the displacement of the stent, especially in the anastomotic area. In most of the cases, in our experience, the stent should not cover the anastomosis as much as possible. How to choose the diameter? Diameter is generally just based on the diameter of the adjacent normal vessel, not extensive oversized, but it's also when it's not should too small. It is not less than 6 millimeter. How to choose the length? Accurate measurement length of the stenosis is important. We should plus to summarize the main stenosis, also the length of the stenotic normal junction. The stent length is should at least a little more than this length, and recommended not too long. Just retain the more vessel to. For the future surgical reconstruction, also to retain the cannulation site as possible. This is the cannulation site, so we put a stent here in order to cover it. This is another case, it's a difficult case, just we should to measure the length accurately, to not cover the both cannulation sites. This is when the stenosis is too close to the cannulation site, we should change the cannulation site. How to measure the lesion length? We will recommend the intravenous measurement using the pre-dilating PTA balloon, because the balloon have the fixed length, such as the 4 millimeter, 6 millimeter. We can measure use it. How about the chance articular stenting? Just articular stenting is possible or not? How to avoid the fracture stent? We have several cases about this condition. Make the stent oblique across the joint rather than the straight across the joint. Is also to select the stent with the better axillary flexibility. Also, the subcutaneous tissue of the elbow joint is loose, so it can buffer the influence of the joint activity on the stent. This make it as possible. Also, we just to check the morphology of the stent after the elbow flex. This is the straight. This is the elbow flex. Only in ultrasound, only find a slight bending of the stent. So this case have no rupture or no the fracture of the stent. Anchoring of the stent is very important in the stent implantation. So we should pay attention to several points. First is to release the stent very slowly. Also to pay attention to the displacement of the stent tip and adjust it timely. Also, we should pay attention to the key moment. The tip of the stent partially expanded, but not yet attached to the vessel wall totally. So this the half expanded, does not touch the vessel wall. So it's the key moment. Just to adjust the location of the stent. That's the last time. Both of the tip and the end of stent are needed to be positioned accurately. It's difficult. Why? We should observe the tip and end of the stent repeatedly to check the position. Jugal eluted stent also can be implanted guided by ultrasound. This is in the cephalic arch stenosis. Just we could put just the implant deploy jugal eluted stent. This is video, but it's not available. Also, how about the covered stent? As to the wide-band stent, the positioning of the stent tip and end was clear in the ultrasonography, but in the initial planted stent can be seen in the ultrasound because of the air in the EPTFE. This material contain a lot of hole, and some airs just stay in the hole, so also can't transit for it. So we just to develop and wanted to develop a new stent, just can be guided by ultrasound. The cover stent. This is a sample, not a product. Product is a sample. Just this sample is in developing all hospital and other company to coordinate to do this stent. It's changed. As can see the upper and the superior and the inferior wall of the stent. So that's all. Thank you.